Hi, thank you everyone and welcome. We're recording this meeting so we can share it with people who are not here today. There was quite a few sign-ups, so we like to share the recording with people, and then we also show them where they can find recordings if they want to later on look at it or watch it with their colleagues, and they can also share it with their other people that they work with. So welcome everybody today. Today's session is about, I was going to say all sorts of tubes, but we're not talking about catheters today. So all sorts of enteral tubes. So we've enteral tubes as well as tracheostomies. And so we're going to try and do 20 minutes on each. So we've got NG, PEG, and we've got tracheostomies. So today I have two lovely people, Cleona and Shanti, who will be focusing on the NG tubes on PEG feeding. And then I will talk to you about tracheostomy. And please don't worry too much about tracheostomies because it's a very niche area and it's part of complex care. So these patients, when they're discharged, the acute trusts will train people. So whether if they're going to their own home or they're going to a care home that caters for complex needs, they will handhold you and they will actually train you and teach you and provide you support for quite a few weeks. At the moment it's over a month as well. If you got any questions, you can bring them up. So you will get all the information you need if you're going to get a patient like that. So please don't panic. This is sort of like a familiarization session. You can take it and we're going to share some information. If you've got a patient at the moment and there are some issues, then we've got Cleona and Shanti with us, so they can help you, put you in touch with the correct teams. Now we cover mainly the BHRUT patch, so if you're outside of these three areas, then you will have a different team wherever the patient was discharged from. And now I know we do have patients coming from Cambridge, Addenbrooke's, and because their homes are local, but they might have been admitted in a different center, so then it gets a bit complicated in that way. So, but don't worry too much about it. If there's any problems, just put it in the chat and we'll try and cover it, and I'll try and explain how to navigate their care. So without further, I need to do housekeeping. So I'm Uzma. I'm a GP in Dagenham, and I work in NELF. So I'm the Deputy Chief Medical Officer for Physical Health. And before I started this job, I used to do lots of sessions and work for a training hub. And this is a piece of work that's coming out of there. It's to create a curriculum and create learning. So we did a learning needs assessment for care home staff and social care staff, and these are the topics that came out of that. And we've created some training resource material for everybody. That's why we have this meeting today. And thank you very much for joining us today. I'm going to hand over to our first speaker, who is Cleona, and I will let her introduce herself. Cleona, over to you.
Thank you, everybody. My name is Cleona Talib. I'm the Nutrition Support Team Lead for BHRUT. And so I have a colleague on here as well, Shanti. Shanti and myself would work very similarly, but Shanti is a dietitian, as you know. I'm not a dietitian. We are a team of nutrition specialist nurses, and we manage and support all patients with artificial feeding. So that could be an NG. It could be a gastrostomy of some sort, because there's lots of different types. I know, lots of GPs tend to call them all PEGs, but like there's lots of different types of gastrostomy. So, we have the balloons, etc. So we work with Nutricia, and NELF have a contract with Nutricia, as does BHRUT. So we work with Nutricia. Nutricia can be our eyes on the ground from a community angle. But I think what's very important for GPs to understand is that we do operate on Monday to Friday a rapid access clinic for these patients if they have problems. So like example, if a patient turns up in your clinic today in your surgery complaining of a gastrostomy problem, I had one the other day in A&E on Monday, and the GP sent the patient to A&E. So ideally, we would try and discourage that if possible at all, only because we can offer a same day appointment in our clinics. And some of those patients, and that particular young patient was a girl with learning disabilities. So A&E can be a really, really challenging environment for them. So I just want to reassure you, we don't work Fridays or Saturdays and Sundays. So that's a whole different ball game, obviously. But Monday to Friday, we are available. And also right now, GPs are, if you've got a patient that you're concerned about, and Shanti, as I say, dietitians and speech and language are involved, and they're recommending maybe they do a referral to the hospital for a gastrostomy assessment and hope aiming for an insertion of some sort of gastrostomy. A lot of GPs are writing to gastroenterologists. And unfortunately, that is proving quite a delay. I'm talking about, you could talk about a month of a delay before the referral eventually gets to us. So it is something I want to reassure the group here that I have raised it at executive level in BHRUT to say that we should be on the ERS portal so that it makes life much easier for all GPs to know how to put in a referral. But we're quite happy, and I have shared our contact sheet with Uzma. We're quite happy for you to email us yourselves. There is a generic email address on that on the contact sheet. So if you wouldn't mind, Uzma, I would really like if you could share it with all your colleagues, and you can just send a referral through that, obviously, and then we go on EPR after that and do some little background investigations. But we'll always aim to see a patient within a week. Sometimes we can do it within a day. It just depends, So that, as I say, is our service. I think GPs maybe need to be aware there's a lot more NGs coming out now, because the head and neck kind of pathway is leaning more towards an NG, hopefully as a temporary measure, rather than going through the gastrostomy insertion route, which we kind of were doing a lot more of a few years back. But obviously that carries with it a lot more risks. So we do have a lot of patients who are going home with NGs, and we are their support network. They have all our details, but some of them obviously may lose those details, so they may turn up at your surgery. Just know that there is a team available Monday to Friday as a support for the GP service as well. So I'm happy to, if anybody's any questions or
anybody. Yeah, thank you, Clarina. So if anybody's got any questions, please ask. We have a lot of care home staff here on today as well, so they're also are they able to ring you up?
Yes,
Your
the care
service,
home staff are the same. Any patient in the community. So like example, sometimes we'll have a patient who's maybe under UCLH for treatment and going there for treatment, but then they have a problem with their tube. Those kind of patients can still come here. They live locally. That's the only thing is we don't provide the same service in King George's. So we tell all our patients our clinic is only in Queen's Hospital. So once the patients get to know us, you will know, because you won't see them in your surgery when there's a gastrostomy issue. They'll come to us. It's a sensible thing to do. Yeah.
I haven't had anyone come to me in my clinics like asking me about it.
Okay, great. I mean, I have to say right now we have a really good relationship with Loxford Clinic. So there's a few clinics we have a really good relationship with, and it's a really smooth run of what we can do and what we can offer. And again, only in the last year they kind of learned that and realized actually we're there. Like, as I say, we're quite happy to attend MDTs at a community level if there's issues. Like we just want to work together with people in the best interest of a patient. And as I say, Shanti, our colleague, is on here. She's one of the dietetic leads in the community, and like Shanti and her colleagues will usually direct you in the right way.
Thank you. So are there any questions for Cleona? Cleona will hang around for a bit as long as she can, and then she'll have to leave. So if you have any questions, was there somebody trying to ask a question? You can unmute yourself and ask. It's all right. You can put your message in the chat as well, and I'll try and keep an eye on it. Okay. I think at the moment they don't have any questions, but at some point they might. And if I can't answer it and Shanti can't, then we will email Cleona and
Yeah,
then we'll get a message
and
back. So we
I'll
can do
hang
it
around for a
later.
little while, so don't worry.
Okay.
I'm
Oh,
happy to
thank
hang
you.
around for a little while.
And I'll share those leaflets with contact details for the BHR. And as Cleona said, that if the
Mm,
patient lives in BHR but they're having their
mhm,
treatment elsewhere, then
mhm.
they will still cater for it.
Yes,
So
yeah,
that's
totally. I
absolutely
don't,
fine.
especially as I say, when it's a very simple procedure for us, because this is our area of expertise. I wouldn't like to see somebody travel all the way up to UCLH for something like that. So we do try and maintain contacts, especially with the Max Fax and ENTs in UCLH. So, but there's always a patient here and there that slips through the net, you
Yep.
know.
Thank you.
Okay.
Thanks. Cool. Thank you very much, Fiona. And over to Shanti.
I prepped some slides. Let me have a go at
Hi.
sharing.
So, most of the people here are from care room, but we're aiming at care room social staff and other clinical nurses, so all sorts of people.
Perfect. Okay, is that coming through?
Yes, I can see it. Thank you.
Beautiful. Okie dokie. So my name's Shanti. I'm one of the clinical leads for nutrition and dietetics, and I'm looking after some of the community services in Barking Dagenham, Havering, and Redbridge. But I'm also the oncology dietitian in Barking and Dagenham as well. So I just thought I would whip together a few slides just to talk about very loosely what enteral feeding does, who does what. I had some tips as well from the dietitians that we wanted to pass over to you, and then I thought we could talk through where to get help if there's ever a problem with your patients and their tubes in the care home. I'll have to forgive me because my throat is a little bit dodgy today, but I'm sure we'll get there. So in terms of what we mean when we talk about enteral feeding, so we're referring to nutrition being delivered into the stomach. It's typically used when a patient isn't able to eat or drink through their mouth. That might be because of medical conditions or maybe because of surgery. These feeding tubes that we're referring to, they're sometimes passed through the nose or they're put directly into the stomach or the small intestines. And the idea behind it is that it gives tailored nutrients to your patients to make sure that they're getting the nourishment that they need when normal eating and drinking isn't possible. So as Cleona said, in the boroughs that we're talking about here, we've got a contract with Nutrition, so they'll often go and deliver the tube feeds and some of the feeding equipment that we refer to as ancillaries. I'm also mindful that in the care homes, I think that the ancillaries themselves are paid for by the care homes there too. So let me move this one on. So in terms of who does what, within the care home, and I need to emphasize this is within your scope of practice, depending on what your role is. You would probably be administering the tube feeds. You might need to test the pH if you've got perhaps a nasogastric tube. You're going to be working within the MDT. You might be contributing to the management of the stoma or the hole where the tube goes in. One of the really big roles that you guys have got is around maintaining the supply of the actual tube feeds and the equipment themselves. You are our eyes and ears on the ground, and so in terms of escalating concerns, that's a really important part. So that might include things like buried bumpers as well. You might be getting involved in some troubleshooting as well. And to that effect, say if one of the tubes that goes directly into the stomach was to come out, you might potentially be trained on how to put a device into the stoma to keep it open. And part of that also involves maintaining your competence in that area. In terms of the dietitians, so what they're going to be doing is they're going to be individually assessing your patients to try and figure out what are their tube feeding needs, and they're going to tailor their recommendations to each individual patient. That might involve writing a tube feeding regime. they might be adjusting that depending on what that patient's needs are, keeping in mind that their tolerance and their needs are going to change over time. So, for example, a patient in an end-of-life situation might not have as big a needs as some of the cancer patients that Cleona was referring to. Dietitians in this area will use Nutritia's MyConnects platform in order to kind of guide the system with what tube feed and equipment they need, and they're going to work within the MDT to do that. And finally, they're also going to be recommending to the GP what feeds need to be prescribed. I wanted to just briefly talk about the nutrition nurses as well. So where Cleona's service is hospital-based, there are also some nurses from Nutritia who are community-based and can and have come out to the different care homes in our area. So from my perspective, I would say they're a bit of an untapped resource alongside Cleona's team. So they provide some training on how to administer feeds, how to use some of the pumps and the feeding equipment as well. They support fast-track discharges as well as palliative patients too, coming from the hospitals into our care homes in the area. They provide education as well on how to administer medications as well. I think one of the big things is they're really great at signposting to different places to get help from during moments of crisis as well. When we talk about some of the tubes that have got balloons in to help keep the tube in place in the stomach, they will often do some of the second changes and beyond. So I think the first change will typically happen with Cleona's team, and then the ones from there can happen there in the care home. And in some instances, they might even be able to change a nasogastric tube. So that's the one that goes through the nose. If your patients are in a situation where some of the tubes need to be taken out, if they've got a balloon in or it's the nasogastric one, they're able to take those ones out in the community as well. And they can provide some troubleshooting. I had a couple of points on here to talk about Cleona's team and colleagues in the area, but if Cleona's here, I'm not going to, I won't go through that one in too much detail. But as she said, we all work together to try and make sure that these patients and yourself as colleagues are supported as they need to.
Can I just check?
Yeah.
The slide is not moved. Is that okay?
That's
Or have
okay.
you moved anything?
That's all good. But I am going to move on now to some hot tips anyway. So I asked the dietitians when I was preparing for this evening what information they wanted to make sure colleagues on the call were aware of. So one of the big things that they wanted to say is that when you're accepting a patient into the care home who has a feeding tube, there's 3 really big things that you want to make sure of. One, you want to make sure that your staff have received the training to be able to look after those patients with the feeding tubes. You need to know how to administer the feed in, do the water flushes, medications, etc. Second thing is you need to make sure that there's a Nutritia account there and you've got access to it. And the third thing, and I would say this is the biggest one, is when the patients come home, you want to make sure they've got, come home to the nursing home or care home, you want to make sure they've got 2 weeks of the tube feeds themselves, as well as any equipment that they need to be able to feed. That then gives the GPs a little bit of time to be able to go and review the prescription, review the discharge, and if things need to be jiggied and adjusted, they're able to do that. The dietitians also said that stock management, I think, was something else that was really important that our colleagues in the nursing and care homes can support with. So we would want you to give Nutritia a call, ideally on a monthly basis, and let them know exactly what your patients need in terms of tube feeds and equipment. You might want to liaise with the GPs as well regarding the prescriptions to make sure that your patients have got what they need. The dietitians also said that when they write their regimes, they'll often pop in some extra water flushes. So the reason that we pop in these water flushes is irrespective of what type of feeding tube your patient's gonna have in place, they're gonna need to flush with a little bit of water before the feed starts, as well as after. And then in the instance where medication is being given, you want to flush before, after, and in between the different medications as well. This allows the tube to be clean, and it helps to keep things nice and patent in that regard. The other reason that we pop in those extra water flushes as well is because it also helps with your patient's hydration needs. And so I'm sure you're well and truly aware of all of the different challenges that happen if we don't have enough fluid in our system. It also helps to address some of the thirst needs that we've got. So the same way in which you or I might want to have a quick sip of our water bottle or have a cup of tea to quench our thirst, these water flushes do the same thing in terms of addressing that basic human need. And the final thing from the dietitians was that when symptoms happen, maybe such as constipation or reflux or diarrhea, it's not always the tube feeds that are causing it. So that was one of the things to pass on there. I had a little contact page up here. I think Usma's going to send out the slides later, but I just wanted to pop in the details of some of the different dietitian teams that you've got. Also, I've just popped up the Barking, Dagenham and Havering ones. I've also got the nutrition support teams there and some of the nutrition details as well. And that is me done.
Thank you. Amazing, Shanti. And Cleona, you have you've mentioned that, you know, any patients that may be a candidate for assessment or consideration needs to be referred by a GP. So ideally, this cohort of patient will already be known to the community dietetics and your SALT teams, so your speech and language teams. So yeah, so the referral bit is through the GP. So you can request, and usually I think the SALT team will probably recommend it rather than I don't know if care homes will maybe they will know from experience that this person now needs this type of feeding tube of some sort, so they will get signposted through there. So any questions for Shanti? I don't know if Shanti or Cleona, you would like to say anything.
Hi, this is Polly.
Hi Polly.
I'm working as a senior care worker in domiciliary setting. So we are not encountered such type of instance, but this is very interesting topic to bring it up. And thank you so much for the the time for you people you are spending, because it's very rare we see to share the knowledge. And especially this is the these critical areas. As a carer, I understand this is very difficult to because we have to be very careful because we are not such trained like you guys. But I had some questions, like my own, because I haven't had experience, but still I've been encountered with clients which is a difficulty in eating, and I have been given them with some of them they have water thickness, they can't drink the liquid form, and I that type of things I've seen. And I feed them, but they have to chew, and because of some autistic people I've seen. But with the GI tube, I never seen any client. But I wonder if any problem, how can we identify, in terms of tube or in terms of cleaning stuff or something? Because as a carer, I mostly look after the hygiene of the tube as well. So how it is been calculated, how it is been it's not the same way, but I do know with the urinary tubes, catheters. So because I know how it's gonna when it is leaking or something like that. But how you find with the GI tube, and that is one thing. And one more thing, for the medication, you said because in some medications are in different type of forms, liquids or solids or something. So how we gonna do that usually? Do we have anything like a crush them and do it, or mix them with the water, or or is there any type of prescriptions?
I can
Yeah.
see Cleona's unmuted herself. I would say, Polly, this is something where your GP of the patient will help you. And when you get a patient like this, you will get the support from the team and they will help explain how to look after this one. I've got a short presentation as well. And in
Okay.
that one, I'm covering these few points
Okay.
that, we clinical bit, how do you know there's a problem? And not all tablets are crushable and putting down because you have to be careful
Yeah.
it doesn't block the tube. So when something has to be crushed and put through, the pharmacist and the GP will support you in that and they'll explain to you how to do it, how to dissolve it and how to use it. But yeah, most of the time ideally we don't want to crush tablets because
Okay.
none of the pharmacy the companies, they advocate crushing the tablets, but we still it's cheaper to crush it and put it down, but most of the time your GP will be able to change all the medications to syrup. Now some tablets don't come in syrups at all, so that's a really difficult question. The pharmacist can crush it and mix it in water and give it to you, but it's called unlicensed specials because you can't guarantee that when you draw 5 mils out that it will actually have any medicine because it could be sitting at the bottom of the bottle. So that's
Agree.
why these are very difficult situations and it's done case by case. So when you have something like that, you should seek the help of the GP or the pharmacist. And Cleona, yes, you want to come in?
And all I just wanted to say to Polly is just remember, if you're ever in that situation, whilst we say we need a GP referral for assessment of a feeding tube, that after that is all done, if the patient has a feeding tube, you yourself can ring my team and bring your client in. Do you get me? So it doesn't have to go through the GP after the fact. Do you know what I'm
Okay.
saying? Once a patient has an artificial tube, then we're happy to help the carers, we help families, we, a patient can self-refer to us as long as it's only when I write that it needs to be a GP who does the actual, it's because that the actual will say gastrostomy or artificial feeding, that has to be a medical decision. That's just a lawful thing that I'm saying. Do you know what I mean?
Okay.
But
Yeah.
other
Yeah.
than that, if you had a patient with a tube, then you can contact us yourselves. So, and then the nutrition nurses are there, and then you've got Shanti. There's lots of support. So be reassured. Don't overthink it right now. That's
Sure.
what I
Sure.
would
Sure.
say.
Definitely. Definitely.
Okay.
Thank you. Thank you so much.
It
I'll
does
try
show
to.
your passion, like you really care about people that you look after. So it is an amazing job, and we've got such a big shortage of carers in dom care that it's absolutely amazing that you choose to do this work, and it's transforming people's lives. So I really appreciate your dedication and passion. So, and I'm
Thank you
sure
so
the
much.
families you look after, they also value your input. So yes, you will get the support when you have somebody like that, and if you have a problem, there's always someone. And if you can't find anyone, then I know we discourage it, but there's always 111. So please do seek out. Don't feel that because we said we don't like you to go to A&E or call 111. If you're stuck, it's the evening, it's after 6:30, it's the weekend. Get help. Don't feel guilty about seeking help whenever you need it. Whatever you think is the best process at that point. But we will share all the PowerPoints as PDFs, so you will have the numbers and the details. So in your email, so you can print it, keep it for yourself, or you can leave it in your inbox and visit it whenever you need to. So that will be absolutely fine. So I don't know if anyone else has got any other questions. You might be able to see yourself for a bit. I'm going to yeah, so I think I'll go through. I mean, I know we're talking about NG tube, so I was going to quickly just show you a bit more. So it's just a quick familiarization thing, and to each person's particular area, you will have your own guidelines. So please do consult that, and you can get them from your GPs or the team that is looking after your patient. Like today, we've got Cleona and Shanti. So obviously, it keeps people nourished and what Shanti covered. But there will be some things that you would need to check, because you need to check is the right patient, giving the right feed to the right patient, is the correct tube. You'll be told all the visible markings, and so for example, you'll be told it needs to be 55 centimeter or something, and then if you suddenly notice that it's actually 40 centimeters, and you see it's 50 centimeters, you know it's got pulled out, you know it's not going to be in the right position, because you know if the tube gets pulled out, the feed can go into the lungs. So you'll be told that what you need to check before anything you put down. So yeah, so don't worry too much about it. You will find out, but this is just to explain what people do. So by the end of this session, you'll be able to tell what's an NG tube, why enteral feeding may be used. You can recognize basic equipment, some tube markings, feeding plans. So I mean, you don't want to put it in until the doctor or the nurse has confirmed that the tube is in the correct position, and if you've got any doubts that you think it's got pulled out, it's not in the right a right area, then yeah, you need to seek help. So yeah, we just try to support the safe day-to-day care, comfort, dignity, and always document in your own documentations. And there'll be some red flags that you can which I'm going to share, so you can then stop feeding if you get concerned. So as Shanti explained, it's the nasogastric nose. It's from the nose and it goes all the way down to the stomach area. So so it's going to bypass all of your, it has to go through the nose, the esophagus, and into the stomach. So it bypasses everything. And it's quite serious because there's airway on the way. So we don't want the feed to go into the lungs. And that's when, people start choking. So I'll tell you what, because Shanti's covered a lot of it. So I'm trying to see, I don't want to cover the same things again. So common reasons she covered, and she said, what does nasogastric mean? Sometimes it's short term or it's transitional. Plan will be to maybe go back to oral feeding, or it might be whilst they're waiting to get a peg fitted, because the peg is in the abdomen. So it does take a bit of time to get that arranged, although Cleona will know how long it takes. When somebody needs one, they need one. So these are the basic equipments. You'll have a tube that will be present. There'll be a pump, there'll be a giving set, and Nutricia that provides the food. The liquid feed actually gives all the training to dom care as well as care homes and nursing homes. Yeah, there'll be feeding water. They'll explain what to do. Can you see these colored papers? And they're the pH strips. So in the stomach we have acid. So we know that when you pump liquids out, you pump a little bit of liquid out and you check what color it changes, because you want to see an acidic liquid, then it's in the stomach. And then people will explain to you that how deep it needs to always measure for that patient, so it's in the right place. And if it's pulled out and you can see there's a different it's a bit like it's like a meter ruling, like you've got that it's got clearly labeled that this is 55 centimeter, this is 40 centimeter. So you will know what is the safe for that patient, safe marking. So, I mean, the golden rule is that you don't put the feed down if you're not sure about the positioning, and you will be told clearly that it's in place. So don't panic. It's not something you have to keep checking. You'll only be told to check the marking. So you need to see that the patient hasn't pulled it out. We get that a lot with dementia, patients with dementia, because they often keep touching their nose and they'll keep pulling things out. So so if you get any problems, like you basically they're coughing or they're vomiting, or you notice that the length has changed, or there's any respiratory symptoms, you'll start hearing a wheeze or some funny noises, then yes, you need to get help pretty quickly. I would say 111 in that case might be a better way, but obviously if they can't breathe, then that's 999. And what I was talking about, the liquid that you take out, so we call it an aspirate. So if you're taking some liquid out and you check it with the the pH paper, I mean, you can tell my age. We used to call it litmus paper. I don't know if it's still called that, but everywhere I checked, it was called the pH papers. So you will know what number you're looking for. So if it's over 5.5, or if it's there's nothing comes out, because in the lungs there shouldn't be any liquid in the lungs, so then you know that it's not in the right place, and then you'll need the help of a doctor or a nurse to actually find out what's happened. This is just a little bit about, this is something that will be provided to you when you're feeding them. They'll tell you how to prepare it, how to position the patient whilst you're giving it, how to confirm it's in the right place, what feed to give, what do you monitor. So you monitor their comfort. It shouldn't be uncomfortable for them. And are they coughing, they're breathless, nausea, pain, and they show you how to feed and flush as well. Yeah, so it's just the same thing again. So daily care, you'll have this chart, you'll fill it out every day. It will be second nature to you. You'll be doing it in your sleep when you're looking after a patient like that. So things that could go wrong is it can get misplaced. You can get a blocked tube. Say, for example, if there was you put down crushed tablets, and there wasn't enough water in it, and it just it's not runny enough, or there were pieces of powder in it and it just gets stuck. So it could be blocked. There could be, people might be intolerant to the feed, because sometimes you don't know if a person, the feed is not agreeing. So there's different types of feeds. So if someone's lactose intolerant, or someone's got IBS, I mean, people won't know until they try this. So you might notice that their abdomen is swelling, they're getting diarrhea, they're getting reflux problem, they're vomiting. So that just means there's something wrong. You need you need clearance team, or you need, I don't think the GPs will know much about it, but I'm talking about from my experience. I should only speak for myself. But I think I would look to the dietitians and nutritionists to give us some advice. I'd be ringing up them myself. So if you can do it directly, that's the best thing. You look for nasal skin damage, because sometimes you'll start to notice a cut near the nose, where that means that something's been really tugged on, or someone is getting very sore for them. Yeah. So if you're concerned, you escalate. So this is just if they start coughing, pretty much the same thing that I said. So just remember that NG feeding is a specialist area, but you can notice if there's something going wrong. And that's where I think your key role is, to see if something's going wrong. So you don't put the feed down, water or medicine down an NG tube unless its position is confirmed. There'll be tube markings. And if you get any symptoms, you can escalate it, and always document things for your own good, because everybody's got their own record keeping ways. So the pharmacist and your GP will actually help you and advise you how to give the medicines. And if you've got concerns, you stop them, you sit them upright, you assess what's happened, and see if it's appropriate to ring the dietitians in the hospital. Is it daytime? Is it out of hours? Is it best to ring 111 or 999 if you think, they're not breathing? And that's the end of my first presentation. I don't know if anyone's got any questions, because I can't see everybody. So does anybody have any questions so far? I will, yes.
Can I just say, and Shanti will
Yes.
agree with me, just to remember for all care home staff, if you've got a patient who's going through, they're not very well at the moment, and they've got an NGN, and actually they're quite agitated, and you're finding that actually they're yanking at it a lot or pulling at it a lot, then if Shanti will agree with me when I say you just need to reach out to the community dietitians to inform them of this, because whilst we do mainly pump feeding in a lot of patients, some patients temporarily pump feeding isn't ideal, because it puts them more at risk in case they yanked at the tube when nobody was looking and the pump feed was actually on flow. Those are the kind of things that put a patient at risk. And sometimes a bolus is right for a little while. So yeah, just remember, you're not alone. People need to remember, you don't feel like you're alone. There is people out there to help you, and also, as I say, the safest thing you can ever do is stop using a tube if you're not sure. Stop using an escalate, and then just wait, because that patient has just missed their meal. It's as simple as that. It isn't really that much more complicated. So it would be the same with a patient who's normally eating and drinking. Just chill a little bit on missing a meal. It shouldn't harm anybody. Okay?
Yeah, thank you.
I might jump in as well. So
Yes, go ahead.
there's so with Nutricia, they've also got an after hours telephone service as well. So they can speak to you over the telephone if you've got some dramas that are popping up sort of, between say 6 and 9. I think the service runs. Cleona, correct me if I'm wrong. They also do video calls as well during that period of time. So if it is, as I say, after hours, which is when you're going to be doing most of the feeding, there's help there as well. You're not alone.
Cool, thank you. Yes, so there's a lot of help around, so don't feel that you're by yourself. And the same thing for the tracheostomies. This is just a short familiarization session. If you are going to receive a patient in the community or in your care homes with a tracheostomy, you'll be given intense training, and it is part of complex care packages. So don't worry if you haven't got one at the moment. Don't worry, if you are going to take one on, you'll get all the training. This is just so that you can feel comfortable and you're familiar with what it is, because we have a big shortage of places where these patients can be looked after, and often these patients end up staying in hospital for longer than they need to because we can't find them placements or places where they can go back into the community. And for them, staying in a hospital is actually quite dangerous because of clots, infections. They can catch all sorts of things, and then also they're away from their loved ones, and so yeah, I think I think it's quite a good idea to explore if your care home can actually take on a tracheostomy patient. So not all of them in this picture, you can see a tube attached. Not all of them need oxygen going through there. Quite a lot of them will be breathing normally. So we just want to see describe what a tracheostomy is, some key parts of it, recognize routine care needs, and know when suctioning is needed, and spot some red flags. So this is just really basic, and it's an overview because you will need to be given more intense training when you actually get a patient with that. So it's a surgical opening which is in the neck, and so it bypasses the nose and the mouth. So the air will go directly through the neck into the lungs, and it sits just between the clavicles in an area over there. And yeah, so in care homes, the focus is that you want to keep the tube absolutely clear, need to check it's secure, and you monitor what's happening with the person themselves. So it has different parts of it. So you can see there's an outer cannula, and this tube sits in the trachea and it remains in place. So it will be stitched in place. That's the one at the top. And you can see it's got a balloon cuff at the bottom, so it stops it from actually getting displaced. It's actually quite secure, so don't panic or don't worry. You won't just remove it like that, it's quite secure in the skin. There is an inner cannula. This is a removable part, and this is the bit where let me just check, that can get blocked with secretions, and then you can clean it and then replace it, but you'll be shown how to do it, because there are some tubes that have holes in them, so they're called fenestrated. Now you don't want to suction with the fenestrated tube because it will damage the trachea. So normally you change the tube and put a different tube in before you suction it. You'll be shown all this, so don't worry about that. So you can see there's a cuff and there's a balloon that the team in the hospital will sort it out for you before they actually send you out. And there's this obturator which is shown in the picture, but you won't see this. This is something that the hospital sees when they guide the tube into the thing. I just put the fenestrated tube warning there, but you don't suction through a tube which has holes in it, because obviously it has the big hole at the end where the air is going in and out. But if it's got holes in this wall, then that's called fenestrated. And that will actually, you can imagine when you're suctioning, it will try and pull the flesh into the holes on the side, and that will damage the skin of the trachea. So that's something that you want to avoid. You'll be shown everything, so please don't panic or worry. So these residents need special attention because, you know, for head and neck cancers or for one reason or another, after an accident, they're heavily reliant on this because they were in ITU for a long time and they need to have this tube in. So basically, it just needs to be clear. The air going in needs to be moist, and the tube needs to be secure in place, and it just needs to be the area around it is called a stoma, just like the stoma people have on their abdomen. It's just I think a fancy name just for a hole in the body, an artificial hole that's been created. So that just needs to be kept clean, and so you'll be given all this training. So the patient will absolutely look fine until a tube blocks or dislodges or there's any secretions. So at every shift, you will be told what to do. So you check the respiratory rate, their work of breathing, their color. You look at the stoma, the skin around it, the tube, whether it's feeling a bit loose or is it still in place. And you'll inspect the area and you'll be shown how to replace bits that you can replace in there. And then you'll need lots of dressing. So all the prescriptions will come through. You will get all of the equipment. Patient won't be discharged until all of this is in place. So there's quite a robust method. And yeah. I'm just going to change. So now suctioning is one that we get a lot of questions about, that when do we suction and when do we actually, let me just move this because I can see your faces, so it's just blocking the slide for me. So when is, you know, what happens is that that suctioning is something that it's like a long tube and it's got it's like a hoover, so it's got a suction in it, and you use it to actually clear secretions that might be inside the tube, because you could imagine if there is some mucus blocked at the bottom of that tube and it's causing the patient to not be able to breathe and they'll be panicking, then this suction is something that can help. You know, they might start coughing, so it will just help to remove the secretions. So you'll see visible secretions in the tube or the stoma. There'll be some noisy gurgling noises. You might notice that the oxygen saturation is dropping. They're trying to breathe very hard, and you can see they're using all their lung muscles. You will know that they're distressed and agitated, and you will know that that's the time that you need to start suctioning again. So you'll be again shown how to choose what tube size to use for suctioning and how to monitor the oxygen saturation. And then you'll be told, like, so you normally suction for about 10 seconds because you need to then let them breathe a little bit, and then you suction again. So there will be some recovery time between when you're suctioning it. And obviously on the oxygen saturation, it shows you the heart rate. So it explains to you, so you know, you'll be explained all this, that what level the heart rate shouldn't drop or how much distress you can they can tolerate. It's not a very comfortable procedure for the patient with the tracheostomy, but it's better than, they will feel a lot better when the secretions have been removed. So there will always be a bedside emergency box. You'll have one if you have a patient like this. So there's always something, safeties within reach. So this box will have a working suction, and it will have the correct catheters in it. There'll be an oxygen supply next to the patient. There'll be delivery devices. There'll be, you know, this bag and valve mask in case you need to do something else to help them breathe. There'll be spare tubes in it. You'll be shown what to do. So there'll be PPE, communication aids, and there'll be a call bell for the patient. I mean, obviously, you always leave the call bell next to the patient so that they can press if they feel distressed or they're in trouble. So every shift you should make sure that you've got all the equipment, even if you haven't used it for months and months. Just always have it ready and handy. And if there's anything missing, you think, or you've used it last time, and always replace it so that it's always there when you need it. So if there's thick secretions coming out, that's a warning sign, and it's something that you can prevent like them from the airway getting blocked. There is people who are on these machines that were breathing it. They need the air that comes through has to be humidified. So you'll need a prescription from the GP, which will be a big bottle of it's just water, but it's got a name. It's basically purified water, so it's free of infections and it's distilled water. That's what it is. And they come in big tanks, like 4,000 mils, and the big and that goes in the machine, and it basically makes sure that the oxygen that is being circulated to the patient is actually has the correct it's humid for them, because you can imagine your nose does that job for you. So when you breathe in, your nose has all the moisture in there, and then it goes into the lungs. But when it goes through the neck, you lose that function of your nose. So yeah, that's what we're trying to replace that. For some people, you'll have that. So you need to report if there's any thick green, yellow blood stain, any foul smelling coming from it. I think it will raise concerns for you, and so you'll need to escalate it quickly. So yeah, I mean, you'll have your communication aid and ways if the patient, because when people have this tracheostomy, they can't speak. So some people have a speaking valve on it. So that can be placed on it when you're trying to understand what the patient is trying to say. But the patient might have a whiteboard, they should have a call bell, or maybe they have an iPad, because, not all patients have dementia or are unable to speak. Quite a lot of people, young people, need a tracheostomy for lots of reasons, cancer, they've had a road traffic accident. So there is a speaking valve that people can use. So if they have any pain on swallowing, then I think, that is something to contact, Cleona's team and find out what's going on. So if there's any red flags, like I said, if you're worried, please do ring 999, because tracheostomies is to do with the breathing, and breathing is very, very important. So the oxygen levels start falling in the blood, the patient will start to go unconscious. So you'll need to call 999. Yeah, so if you think it's blocked, there's no air going in, then please do ring 999. If you notice blood coming out of the tube, it might be that it's got pulled or some trauma has happened. So if blood's coming out, that's 999. And especially if the person's going drowsy, is getting confused, is panicking, or after like being low oxygen level for a while, people start to get tired and sleepy, so they might look exhausted. And you don't want to leave this person alone. So you will need to, even if you need to go and ring ambulance, you need to make sure another carer or another team member is with the person, and that person is adequately trained in basic life support. Yeah, so this is basically your basic life support. You will call 999, get help, and check, and then you can check what's actually going on. Is there something you can do? But try and get help as quickly as you can, especially if you think that there is blocked and they can't breathe. So you will be, when the ambulance comes, because these patients will be in a nursing home, they will expect you to have worked out what's their respiratory rate, what is the oxygen level, the work of breathing. All these things really help the ambulance crew to actually understand what's going on and assess and how quickly they need to take over. If you're talking to a doctor, they will like to know how much secretion's coming out, what's the thickness, is it smelly? Because we need to know, is this infection? Yeah. Yeah. So call for help. They can help you assess the oxygen. It's not a problem. Just call for help. And then get all the equipment around the patient and just be ready if there is something happening. But this is only if you notice there's a problem. Majority of the time, these patients are absolutely fine. They don't need anything. So the take home messages is just to remember airway always comes first. So if it's blocked, you need to get quick help. And routine care, if you follow the procedure like you're explained to how to keep the area clean and how to check if it's in place and what's happening, any problems, if there's any coughing, breathing distress, if you escalate it quick enough, then it prevents it from getting to that point where everybody starts to panic, and just escalate it early. So these are just some references, like if you want to read up later on, I'll share these as PDFs, or maybe just a normal presentation. So just you can read it up later on if you're curious, if you want to know a bit more about this. But yeah, but that's just all of it. I'm going to stop sharing. So if anyone's got any questions, please do ask or put it in the chat. We did start a few minutes late, so we've just gone 7 o'clock, but I'm happy to hang around a few more minutes if anyone's got any questions they would like to ask. We've still got Cleona and Shanti. Everybody's very quiet today. Normally, everybody does ask a lot of questions, so...
Yeah. Hey, my name is Orca, and I'm not here, but I don't think so I have any question. You cover the whole area very well. And
Oh, thank you.
Yeah.
Oh, thank you, Ansa. Thank you very much. And remember, you can always send your questions in. So if there's any problems, then we can obviously answer your questions. And we'll share all the all the PowerPoints and details of how you can get help. And if you're not sure, then, you've always got your GP. And even if you Google it in your area, if it's covered by NELFT, you'll get all of the numbers that you can ring. Someone will be able to guide you. But if you're panicking, 111-999 is absolutely fine. Cool. I think if no one's got any questions, then we'll just close the session. And thank you, everybody, for attending. And thank you, Shanti. Thank you, Cleona, for attending today and giving your time.
Thank you so much for you guys. Thanks so much.
Thank you, Ansa.
Pleasure. Thank you.
Thanks for having us.
Thank you very much. Thank you.
Thank you so much, everyone.
Thank you, Polly.
Thank you so much.